very successful first session last month, so I'm looking forward to this second session. And today we will be looking at the question of what has been the impact of outbreaks on the use of health services and how can these effects be mitigated. So we have three speakers today, and I will read a brief bio about their impressive backgrounds, and then we'll have the talks, and then a question period will follow after all the three talks have been given. So the first speaker is Karen Grépin. Karen A. Grépin is an associate professor at the School of Public Health at the University of Hong Kong, and she is a health economist and health systems researcher. Dr. Grépin's research focuses on institutional factors affecting the demand and supply of health services, the politics and effectiveness of development assistance for health, and the role of routine health information systems in strengthening health systems. She has a PhD in health policy and economics from Harvard University and an SM in health policy and management from the Harvard School of Public Health. And she will start off the talk, but it's a joint session with Celestin Hategeka, so I will introduce him here as well. Celestin Hategeka is a Banting postdoctoral fellow at Harvard University. Dr. Hategeka studies health system performance and policies targeting health system improvement. His research generates evidence that can help inform optimization of effective coverage of health interventions to ultimately improve population health outcomes and people's confidence in health systems. Before starting his research career, he practiced medicine, and he was also involved in implementation of health system improvement interventions in Rwanda. Dr. Hategeka holds a PhD in health services and policy research and an MSc in population and public health from the University of British Columbia and an MD from the University of Rwanda. So thank you both for participating today, and we will start with Professor Grépin.
Great, so I am going to attempt to share my screen, and let's hope this works out. Please tell me if you cannot see my slides.
So far, so good.
Great, that never happens on the first try. So thanks everyone. Thanks for coming today. As was mentioned, this is sort of a joint presentation, so it's a little bit of a tag team. I'm going to go I'm going to pass it over to Celestin for a bit, and then he'll pass it back to me. And so the broad overarching theme of this presentation is, what is the impact of outbreaks on the use of health services? And we're specifically going to use lessons from Ebola and COVID in the Democratic Republic of Congo to inform at least what's happening in some parts of the world. The work that we'll be presenting, it comes out of an IDRC sponsored research project that many of the other people on this call were also a part of, which was looking at specifically the role of routine health information systems and how we can leverage those systems to better understand in real time what's happening in health systems with regards to health service utilization. And so I'll leave that to Celestin to tell us a little bit more about why that's important to look at and why routine health data is an important source of information to help answer some of these questions. But I just wanted to briefly introduce some of the members of the team that we've been working on with this project. So I just hope you can see my screen. There is a reasonably sized literature out there that has looked at this question in terms of understanding what has been the impact of outbreaks, different kinds, on health services. In fact, going back to my dissertation, one of the topics I looked at when I was doing my PhD was really what was the impact of the HIV pandemic on the use of health services. And then I've been sort of involved in this kind of area of kind of what happens when one thing gets prioritized within a healthcare system, and does that sort of crowd out the use of other health services or the priority that's given to other health services. And as I said, there is this kind of emerging literature that has really looked at this idea that outbreaks, and by this I mean the virus as it spreads through society, as well as the way we as society, government, respond to these outbreaks, can have relatively important and usually very unintentional effects on health systems. These are sometimes known as sort of collateral damage, in that because priority gets shifted to one part of the health system, other health service utilization drops off, and this can lead to negative health effects. As I said, there is a reasonable literature out there. Most of it at this point comes largely from Ebola, largely because we've never, at least in recent history, experienced a pandemic of this nature, as we have and we're going through right now with COVID. So most of our examples are now, in retrospect, small in comparison to what is probably likely happening in real time right now around the world. But we do know from, for example, a number of systematic reviews that have been conducted post-West African Ebola, that reasonable, relatively large reductions, I mean, depending on what your definition of large is, but these are quite substantial declines in health service utilization have been well documented in at least in that particular instance. So for example, about an 18% decline in overall health service utilization in the 3 affected countries. And we know that certain types of health services tend to get more affected than others. So, strong effects, in particular on women and children, are the groups that seem to be most affected. And because there are these drops in use of health services, there's also been reasonable evidence that there's been health effects of these as well. So, for example, increased rates of child and maternal mortality are likely in the context of Sierra Leone. Excess mortality related to, for example, malaria has also been at least predicted to have happened in West Africa during the Ebola outbreak. The challenge, of course, in most of where Ebola struck in West Africa is we don't have great data on mortality, and so it's actually quite difficult to document that it in fact happened. But at least the models predict that it was likely quite substantial, and to the point where it may have actually killed more people or had more of a population level effect than Ebola itself. It's not just a low-income country setting. In fact, where we've seen studies that have looked at this in other contexts, we've seen it also well documented in high-income countries. These studies are also starting to be documented around the world right now in COVID in high-income countries too. So this is really a global phenomenon. So for example, when MERS was in Korea, well documented examples of drops of health service utilization amongst the general population. In Canada, when there was SARS, as well as Hong Kong, where I am now, when SARS hit, there were, again, these well-documented declines in health service utilization amongst the general public. So to be clear, I'm really talking about use of health services for things that are unrelated to the infectious disease outbreak itself. Another point that's really important to make is it is especially during infectious disease outbreaks that we want to ensure sustained use of health services, not just for population health reasons, which are important, obviously, but also because it can actually play a really important role in the outbreak itself, right? So we can think of people presenting to clinics as a way as a method of surveillance to understand who has the infectious disease that we're trying to detect and to address. And so it's really important that we want people to come to clinics who have the disease as well to present early in order to ensure that they get the care that they need. So why do these things happen? Here our evidence is probably less clear, but again, there is some literature out there that suggests what might be some of the common reasons why health services drop when there are these infectious disease outbreaks. Clearly, there are disruptions that happen within the healthcare system, and that can lead to, for example, people who are on chronic care treatments or other types of services like that, not being able to come in and get all the services they need when they need them. So sort of interruptions to protocols and other types of things. There is also a tendency for routine health services, in particular immunizations in low-income settings, to be suspended, mostly because all energy is being focused on something else. But also for concerns around, for example, in the context of Ebola, sharing of needles or things that might actually lead to increased transmission, suspending of those types of services as well. But there's, broader, more severe, to some extent, supply side factors. So, for example, in West Africa, there's a lot of examples of health worker absenteeism, in particular, in settings where there was not adequate levels of personal protective equipment being made available to the health workers, not wanting to expose themselves to risk, and so not coming to work quite logically. But also a lot of mortality. So, especially early on in the outbreak, there was a lot of transmission to health workers, and a lot of them were amongst the earliest to die. And so estimates of anywhere between 1% to 8% of the total health workforce in some of the West African countries likely contracted and died as a result of Ebola. But more other effects too, clinic closures, whether they can't provide the services that they want, so the clinics actually close, or health workers going on strike because of issues related to the outbreak themselves can also lead to these types of situations. And there's likely also really important demand side factors. So, for example, communities or individuals being worried about potentially getting infected by coming into a clinic. So that fear of infection is probably something that keeps people from coming in for services that they would otherwise. But also, other factors, if I felt that my government was doing the right things to protect me, I might be less likely to avoid those types of services. So factors like trust, or how much I feel that the response has its act together, might be influencing the way in which I interact with the health system otherwise. And so that kind of background was really the inspiration, or the logic for getting involved in the DRC about 2.5 years ago now, looking at the impact of what was at the time seemed to be an increasingly growing out of control outbreak of Ebola in Equateur province. We began looking at this question about how does Ebola affect the use of health services. All those studies that I mentioned earlier from West Africa, many of those took many years to write, largely because the data that were necessary to write those studies didn't come out until years after the outbreak was over. And so, one of the things that we've been working on in the interim was really looking at the way in which we can leverage routine health information systems, even in relatively low-income country settings, to be able to track almost in real time what's happening within the health system during an infectious disease outbreak. Sort of the perfect example of why we really need timely and high-frequency data on what's happening within healthcare systems. And so, so we started this project sort of, saying, what can we learn about the impact of Ebola on the use of health services in the DRC? And as I said, Celestin will be presenting some of that. And then, one of the things that we were thinking about at the time is, how can we prepare for the future, the next big outbreak or the next big thing? And little did we know that not only would there be 2 more outbreaks of Ebola during the length of this project in the DRC, but that we would be faced with COVID. And so, as a result, we've been able to sort of expand what we've been doing to really track these 4 separate different events. And we'll be presenting some of those results here tonight. So I will stop there and I'll pass it over to Celestin.
Thank you very much, Karen. So let me try to share my screen so I can. So my talk will focus mainly on the impact of the Ebola outbreak in Eastern DRC. So, and then I will also discuss the impact of a free healthcare policy that was implemented to help mitigate the potential impact of the outbreak. Are you able to see my screen?
We see a blank screen with a pencil moving around.
I don't know why. I'm trying to. Okay. Can you see it?
Yes. Now we see it. Yeah.
Thank you. As I said, my talk is going to build on the introduction that Karen very nice introduction in the background of outbreaks and impact of outbreak on service utilization. I will focus on the Ebola outbreak in the Eastern DRC. So before I dive deeper into that, let me give a quick background on the Ebola in the Congo. As many of you are familiar, the Ebola outbreaks was actually discovered in the Congo in the 1976. So since then, there have been several outbreaks in the DRC. So including 2 outbreaks, the outbreaks that Karen mentioned. There are 2 outbreaks that happened in Equator, in this area of the region. So the one in 2018, starting in 2018, and the most recent in 2020. So my talk today is going to focus on outbreaks that took place in the Eastern DRC, this part of the DRC. So these outbreaks also started in late 2018. So it was it affected 3 provinces, but the outbreaks in the South Kivu was relatively small in one health zone, and it was contained. However, the outbreaks in the 2 other provinces, these 2 provinces, the Ituri and North Kivu, was more severe and it lasted for several months and affected several health regions within those provinces. So recognizing the impact of the outbreaks on service utilization, the government, working with its partners, introduced a free healthcare policy immediately in some region, immediately when following the outbreaks. So the outbreak that given that the free healthcare policy was not introduced in all health regions, so we have opportunity to sort of understand the impact of the free healthcare policy on service utilization in the health region where it was introduced. But at the same time, we were also able to understand the impact of outbreaks in Congo in regions where the policy was not introduced. So we are able to do that because we can leverage existing routine health facility data that are collected at the facility level. This data, they have been expanding in many low and middle-income countries. Currently, there are over 65 countries that collect these facility level data using our web-based platforms. So they are collected at each facility across the healthcare system and then are submitted into the system, so they are available centrally. So they offer a distinctive advantage of being relatively timely, and they are also cheap because they are already there, so you can use them. They are longitudinal, so they allow to sort of study the impact of any outbreaks or policies by using long time of data before the policy or outbreaks and the period following the outbreaks or any response policies that may be introduced. So, however, although these data are very valuable, so users should keep in mind that they also have a limitation. Many of the limitations are related to the quality of data, and therefore this requires sometimes a sophisticated approach to deal with these data. So some of the data quality issues includes a presence of many outliers and missing data. This really might require sophisticated approaches to make sure you handle them very well before you use the data for analysis. So in this study, we were interested in understanding the impact of the outbreak and the free healthcare policy on common primary healthcare services. As such, we looked on use of clinic use or consultations, outpatient consultations for all services in general. And then we look specifically at the utilization of common infectious disease, including diarrhea and pneumonia. So we also examine the impact of outbreak and the policy on use of maternal health services, including antenatal care. services and delivery care and postnatal care. And lastly, we evaluated the impact of the outbreaks and the free healthcare policy on use of preventive services such as vaccinations. So as I mentioned, these data are corrected monthly, so they are time series data. So this really offer an opportunity to use a strong design such as this one we use in interrupted time series. This leverage the wrong time series data before and after the policy. So this is an appropriate, a methodological appropriate approach because it allows to study the longitudinal changes in outcomes that we are interested in, while also controlling for pre-existing trends in the data, which are important to adjust for, but also autocorrelations in the data, which is common because many of these observations are successive observation over time. So this approach really allows us to sort of account for all these and provide an robust evidence. So they are based on whether a control group is used. We typically classify these methods into two. There may be, when there is no control group, we call it a single interrupted time series or a controlled interrupted time series. In these cases, we are comparing longitudinal changes before and after interventions in one group. And then in contrast, when you have a control group, we are comparing longitudinal changes before and after the intervention, between the intervention and the control group. So the parameter of interest that we are looking at in these two approaches, it's the level change, which is the immediate changes in the outcome of interest after the policy or any intervention or outbreaks. And then this one here, and then here. And then change in the trends or slope, which is the overtime changes after the introduction of the policy. So in our case, we use, because we had, as I mentioned, we had the free healthcare policy was introduced in some health zones that were affected by Ebola, leaving other health zones without the free healthcare policy. But also we had health zones without Ebola and free healthcare policy. So we're able to use a control interrupted time series, which is more robust. So, and then we're able to control, to look the impact of the intervention, the free healthcare policy, and Ebola relative to the regions that did not have Ebola and free healthcare policy. So we typically use a segmented regression approach to estimate the impact, to quantify the impact, the level change and the trend changes. So in our case, because we use the facility level data, we also added a mixed effects to sort of adjust for clustering of observation at the facility level. And we accounted for seasonality in the data as well, because as you might be familiar, the use of services may fluctuate depending on the seasons. So what did we find? So when we look at the overall of the total clinical visit, if you look at this time series, so we found that immediately, if you look, let me provide a quick background here. So we have three groups. So the blue ones, the region, the health zone that had the Ebola and the free healthcare policy, and then the sky blue is the Ebola without healthcare policy, and then the orange group, this is our control group. It's the region without Ebola, and then free healthcare policy. So if you look at this time series of all of clinical visits per 1,000 population, you can see that immediately after the Ebola start and then and the free healthcare policy was introduced, so the use of services, the clinical visit more than it doubled. So in this group, in the Ebola and free healthcare group, free healthcare group policy group, are relative to our control group, which is the orange group. So however, the services did not continue to increase significantly over time. So however, when you look at what happened in the Ebola regions without healthcare policy compared to our control group, so you can see that there was no immediate increase in the services following the Ebola outbreak. However, as you can, over time, you can we can see that services started increasing over time in the Ebola regions relative to control region. This might be attributed to subsequent increase in social location in this area. As outbreak remained there, there could have been increase in the social location that might have also affected the utilization of services. So when we examine the impact of the outbreaks and the free healthcare policy on the use of services for common infectious disease, specifically we looked at diarrhea, and then as you can see here, diarrhea, the use of services as well in the region that had Ebola and free healthcare policy more than doubled immediately following the introduction of free healthcare policy. So, however, the trends in the service utilization decrease over time in the for diarrhea compared to a control group. One potential reason could be because there were a lot of campaigns to motivate people to, to adhere to more hygienic measures like cleaning their hands. This could have contributed to preventing the incidence of diarrhea. So when you look, we also looked at the trends in pneumonia, use of services for pneumonia. So we found that immediately, similar to what we observed to diarrhea, immediately following the free healthcare policy, the outbreaks, the service utilization increased more than twofold. So relative in the Ebola and free healthcare policy relative to our control group. However, there was no major really increase in the region where there was Ebola, but without free healthcare policy. We look, as I mentioned, we also examined the impact of the outbreaks and the free healthcare policy on the use of maternal health services, specifically on antenatal care visits. As you can see, when looking at this time series of antenatal care visit, so the service utilization increased immediately after the free healthcare policy was introduced. The increase was about 17%. So in the free Ebola and the free healthcare policy relative to the control group. And then when you look at the delivery facility, the use of facility, delivering at the health facility, so you can see that the service increase as well following the introduction of free healthcare policy. Here, I should provide some context. So the free healthcare policy was introduced in the mid 2018, but for delivery care, it was stopped in early 2019. So this really helps to show how the effect of outbreaks and how the effect of the free healthcare policy, and then how the effect also stopped when the free healthcare policy was stopped at the same time. So you can see immediately after a month after the introduction of free healthcare policy, use of services for delivering in health facility increased by about 45% immediately, and then it continued to increase at a rate of about 4% per month in the region where there was a free healthcare policy compared to our control group. And then when the free healthcare policy was stopped in early 2019, the use of facility delivery dropped by about the same amount it had increased at the beginning, by about 40% immediately when the free healthcare policy was stopped. and then it continued to drop at a rate of about 16% per month. This really show is how the free healthcare policy had impact on use of services. When we look on the postnatal care, we also observed the same trends as what we observed for use of facility delivery. So these two charts showed the use of postnatal care 1 and postnatal care visit 2. So lastly, we examined the effect of outbreaks and the free healthcare policy on vaccination, specifically looking at the rate of DTP1. So as you can see, we did not observe any significant change in the use of vaccinations, either in the region where there was a brand free healthcare policy, but also in the other regions where there was no free healthcare policy. So in short, our study shows how this free healthcare policy had really significant impact at the increasing use of services in the Ebola-affected region, and then overall the effect was sustained during the free healthcare policy, and then it stopped when the free healthcare policy was also stopped, highlighting that free healthcare policy might be an effective strategy to mitigate the adverse impact of infectious disease on infectious outbreaks on service utilization, such as Ebola. These studies also really highlighted the vital role of routine health information data, as we were able to really study the impact of outbreaks and free healthcare policy, leveraging existing routine facility data that has overall been underused. However, this shows that these data are valuable and should routinely be used to study the impact of outbreaks or response measures. Thanks, back to you, Karen. This is again the group that was involved in the study, as Karen highlighted. So over to you, Karen, to walk us through the next.
Thanks, Celestin. I think you just need to stop sharing your screen and then I can share mine.
Sure, I did.
Thank you. Great. So I'm going to now take us to COVID world, if that's okay. So as I said earlier, one of the goals that we had with the research project was to even start thinking about how what we were developing in terms of approach to understand sort of real-time changes in health service utilization could be integrated into future outbreak responses. And as I said, we were quite lucky. We got to look at, for example, the impact in the Eastern DRC that hadn't been planned. But of course, earlier this year, as COVID began to spread around the world, it provided a real-time opportunity for us to again think about what was going to be happening with regards to health service utilization in the DRC as a result of COVID. As I said previously, all expectations were that there should be a relatively large decline in use of health services because of all those factors that we've mentioned: potential fear, potential disruptions to the supply side, potential changes to people's demands for health services. We just demonstrated that in the DRC, policies like free healthcare can actually have a huge role in terms of mitigating the use of the impact of these kinds of events on health services. So what would we predict would probably happen? There were at the time a number of modeling studies that were being conducted in settings around the world, really trying to estimate what the potential impact of COVID was on other health services, so that collateral damage. And many of the projections were actually quite dire. A report coming out suggesting that malaria deaths under certain scenarios could actually double in sub-Saharan Africa this year as a result of the neglect because of COVID. A lot of other concerns around other priority infectious diseases were there, HIV, and so on and so forth. But it's very difficult in real time to understand what's happening in these countries if one doesn't have a really high frequency data like routine health information data. So it really provided us with an opportunity to ask some of these questions in more or less real time. So the outbreak in the pandemic, I should say, of COVID in the DRC followed a similar pattern to what we've observed in many sub-Saharan African countries. So there wasn't a lot of awareness or potential of cases or known cases in these countries until about mid-March. And so that was in fact the case also in the DRC. And then there was sort of an increase in the number of observed cases. And then many countries implementing relatively large-scale response measures in response to the threat of COVID. And so all of that happened in the DRC as well. And so what we saw was a sort of gradually increasing severity of the response measures. In the beginning in the DRC, most of the cases were imported. And so the early outbreak was really centered on the capital of Kinshasa. In particular, it was very much centered on one of the wealthier neighborhoods actually of Kinshasa called Gombe, where presumably the international travelers had brought the virus initially into the country. And so there were quite extreme measures introduced in Kinshasa. So the whole city of Kinshasa was sort of cordoned off at one point. And then in another version of this, the neighborhood of Gombe itself was put into sort of what we would call now full lockdown mode. And it was in that for a number of months. As of today, there have been about 13,000 confirmed cases of COVID so far in the DRC and 344 deaths. And they are currently experiencing what we would call their second wave. However, we'll be really focusing in on what happened during the first wave of the pandemic. This is the city of Kinshasa. I mean, Kinshasa is an enormous city. It has 12 million people in it. It's one of the most densely populated cities in all of the world. The area that we'll be talking about specifically, Gombe, is a neighborhood, as I said, one of the wealthier neighborhoods. It's the number 5 on this graph, if you can see that. The way the health system is organized in the DRC is that there are a number of health zones, and those are further segregated into health areas, each of which would have a series of health posts, health centers, and hospitals serving the general population. I won't spend too much time on the methods because we effectively are using the same methods that Celestin has just outlined for you in Eastern DRC, but effectively using data, monthly data from the DHIS to HMIS system from early January through to the present. In fact, we've updated this more recently now through October. We chose indicators that we thought had really high levels of reporting, but also try to capture different aspects of what was going on within the health system. And so kind of a mix of different types of health services. And again, we use this interrupted time series approach to analyze what was happening in real time in response to the onset of COVID in the country. And so we started looking at this probably back in March or April of this year, and as the data were starting to come in from across the DRC. And so the early patterns looked a lot like this. So we were seeing, first off, there was kind of a big jump and something happening in the DRC in December and January of this past year. It seemed to be too early to be anything related to COVID. And I think the current belief is this has nothing to do with COVID. There was likely some form of either malaria or very severe pneumonia that was passing through the city at the time. And so it led to a blip in terms of total clinic visits. So we actually exclude that from our analysis because it does somewhat shift our results if you include that into them. And then we define the onset of COVID to be effectively March. And as you can see here, there is some sort of drop. And in fact, what the interrupted time series allows us to do is actually to be able to put a number behind that. And about a 20% drop in health service utilization at the outset of the pandemic. No major continued decline or anything after that. But it wasn't the sort of very dramatic declines that were being predicted by a lot of the modeling studies that were happening at the time. But then we decided to dig a little deeper into the data. In fact, once we started disaggregating the data, so for example, we split it up by hospitals and health centers, we started to see that there were somewhat different patterns within the data. And so, for example, here we see that most of the declines were actually centered on hospitals as opposed to health centers. So we know that in the DRC, most of the COVID patients were being treated in public hospitals. Perhaps this result was the result of people fearing the fact that there were Ebola COVID patients in the public hospitals and deciding to stay home. And we continued to dig deeper into the data. As I mentioned, one of the neighborhoods was very severely locked down for a couple of months. And so we actually split it by neighborhoods that had this lockdown versus not. And here we see that, in fact, almost all of the declines that were observed in the data were actually centered on that one neighborhood, which is a large neighborhood, but that one neighborhood that was locked down, and that for the most part, the rest of the DRC, of Kinshasa wasn't experiencing that much of a major decline in use of health services, which is kind of interesting. And you can see too that a couple of months after the introduction of the policy, the measures were relaxed. And at that point, we actually start to see use of health services rebounding in that neighborhood that had been locked down in Gombe. If we look then by different types of health services using that same framework of lockdown areas versus non-lockdown areas, we definitely see that certain health services more affected than others. So I'm just going to show you a couple of them here. Here is the number of malaria cases treated in clinics. Again, we do see a decline in the use of health services that's quite severely focused on the area that experienced the lockdown and not so much in the rest of the city where this lockdown policy was not in effect. One of the more interesting findings we found is that there were quite dramatic declines in hypertension and diabetes. So in the non-communicable diseases, most of the modeling exercises and so on that had been done all focused in on this infectious disease threats. And in fact, where we saw the biggest drops were in the non-communicable diseases. So hypertension, this is the data for diabetes. So just really to summarize all this, we did see a relatively observable and noticeable drop in use of health services, but only on the order of about 20%, nothing as extreme as what was being predicted by some of the modeling results that have been circulated around early this year. However, almost all of it was very heavily focused in on Gombe, 80% in Gombe and only 15% elsewhere. Some services were affected more than others, as I said, sort of 25, 80% drops, depending if you're in regular Kinshasa or in Gombe for some of these infectious diseases, but really severe drops for the non-communicable diseases. And however, most of this effect was quite short-lived, and it seems to correspond very much with the timing of the introduction of the lockdown measures. And once they were removed, most of the utilization of health services did rebound. And so it really does raise this kind of important question about, what were the health impacts of the lockdowns and whether we can make the trade-off between the health effects that come from COVID with the health effects that were potentially coming from some of the other health services. So I'll stop there, and I look forward to your questions later.
Okay, thank you, Karen and Celestin. A lot of interesting findings, very vividly presented. So I'm sure there will be questions on that for, later on. So now we will move on to Rochelle Frounfelker. And Rochelle Frounfelker is a postdoctoral fellow in the Department of Psychiatry at McGill University. Dr. Frounfelker obtained her SCD in social epidemiology from the Harvard T.H. Chan School of Public Health and an MSSW and MPH from Columbia University in New York City. Thank you for joining us, Dr. Frounfelker. And I hand it over to you. I still see on the screen, Karen. I think you have to stop sharing or whatever. Yeah. Okay. I think, yes, Rochelle, we see your screen now.
Right. Hi, everyone. Good morning, afternoon, evening, wherever you may be at. So What I'll be doing is very much pivoting to a different topic in a different context. But the focus of my work is on mental health. So I'd like to talk about sort of in the earlier presentations, this discussion of unintended consequences. And I think the topic of mental health and psychological distress as an additional issue that's come up because of COVID is something that has certainly been discussed in the literature and is being discussed more broadly in the population. In terms of and so today I'd like to talk about using a case example looking at the province of Quebec in Canada and looking at the consequences and the experiences related to social distancing and the impact on mental health. And I think I would say more broadly when it comes to mental health services is to say, you can certainly identify there's an increasing need for mental health services here in Quebec. My colleagues that are clinicians have talked about an increase in waiting lists for mental health services, people going to emergency rooms to utilize for mental health reasons. And so I think when it comes to our mental health services, we need to think about, we can certainly say we need to have more services for people, but also to be smarter in identifying those individuals that are most at risk for adverse mental health problems, and then think about innovative interventions that can be both clinical health services, but also more broader programs and policies that can be used to address the mental health needs during the pandemic. So today's talk, I'm going to briefly talk about this idea of epidemics and mental health and stress and coping. What do we know? Then talk a little bit more specifically around COVID experiences in the context in Quebec since March of this past year. And then we're specifically talk about a study we conducted using latent class analysis to identify subgroups of populations related to their experiences of social distancing and self-reported mental health outcomes. And then from here to talk about public health implications. And one thing I'd really like to say here about this talk, and I hope we can add to sort of the body of literature on mental health and mental health needs during the pandemic, is to say that less attention has certainly been focused on how COVID adversities may be positively mobilizing individuals and groups. And I think this is really important information for us to have when we think about how do we build resilience among individuals and in populations, and in building on what is going well for people already and right now, and to build on that and focus not just on deficits, but also strengths that people have. So in general, when we look at stress and coping and epidemics, certainly past research on mental health and epidemics, it mirrors what we see today with COVID. So stressors such as disruption of our daily routines, or lack of information, fear of contagion and isolation are certainly been associated with past epidemics and issues of depression, anxiety, and feelings of fear. And then some very common coping strategies that have been used effectively include seeking and utilizing social supports, avoidance or denial of some of the negative consequences of a pandemic, and also positive reappraisal, and to look at what might be the result of the pandemic in ways that have been of benefit to an individual. And I think these are sort of these stressors and coping strategies resonate certainly with COVID-19 and what we ourselves have experienced during this. And what I'd like to talk about is when we come to and looking at stress and coping and mental health during pandemics, to think about something called the conservation of resources theory. And this theory really focuses on objective resources in producing psychological distress. And a central tenet of conservation of resources theory is that individuals are always working to build and maintain resources that will help them get through difficult events. So stressors, which could be acute and intermittent or chronic, results in a loss of objective resources or a lack of resource gain. That is what creates psychological distress. And so individuals can then successfully cope with those stressors by conserving and building new resources or reappraising their existing resources. And the final component of this theory is to say that our resource losses and gains are developed and exist in aggregate. And so successful coping is dependent upon resource caravans dissolving or staying intact or being rebuilt. So next, to say briefly the experience of COVID in Quebec from March to June in the first wave. So there was a shutdown that started on March 13th, which there was the widespread closure of schools and businesses, anything but essential services. We look at sort of the health and socioeconomic impact to say that the April unemployment rate in Quebec jumped to 17%. And of course, schools were closed with a gradual reopening beginning in May and in June, with a slight difference in the reopening from the greater Montreal area because of population density and the number of cases and deaths in the greater Montreal area as compared to the rest of the province. Now, we conducted a survey, an online survey through a marketing firm here in Quebec between June 1st and June 23rd. So it was in the progress of a gradual reopening of activities. The focus of our survey was on COVID experiences in mental health. And that included experiences of exposure to the virus, experiences of COVID-related discrimination and stigma, and it also included questions about positives and negative experiences related to public health guidelines of social distancing. So our research questions for this specific analyses are asking, are there sort of subtypes and subgroups of individuals in terms of these experiences around social distancing? And can these subgroups, do they vary in terms of some of their sociodemographic characteristics? And then ultimately to say, are these subtypes associated with mental health? The overall goal to say, can we identify, again, those groups of individuals based on sociodemographic characteristics, and experiences around public health prevention activities that are at heightened risk that we can target for mental health services. Our survey ended up, we enrolled over 3,000 individuals. This is the brief demographic information about our sample. Of note here, which becomes important, is we did ask for self-reported prior mental health before the onset of COVID. We purposely oversampled from more visible minority populations because we were interested in identifying sort of at-risk populations based on sociocultural issues. And then we did have, as with many online surveys, you find over almost 50% were of the younger age group. And I'd say overall, which we don't have here, but it did become important for us to separate out and look at people that greater Montreal area versus elsewhere in Quebec. About 2/3 of the sample came from the greater Montreal area. So just a general interest is to say, what were some of the positives of social distancing that and prevalence of what people were reporting? Is it, overwhelmingly, we had 80% of the sample that were saying the benefits were increased feelings of safety and protection. We also had people who talked about stress reduction overall and reduced stress related to work and related to commutes to work. And being able to have more flexibility in their schedule, either spend more time with their family or more time alone than they had before. In terms of negatives, as you would expect, a negative of social distancing is limited social contact. And then we also had people identifying things such as an increase in family conflict since before COVID. Challenges in balancing work and homeschooling if they have children, and also financial hardships that range from a loss of employment, closure of a business, not having enough money to feed your family, and things like that. So we use a latent class analysis approach to identify different classes or groups of people based on their probability of how they responded to these both positives and negatives of social distancing. So here in this graph, you can see we came up with a 5-class model and labeled them in parentheses as the percentage of people that were within this class among the overall sample.
Sorry, Rochelle, just to interrupt, we don't see the graph on the screen.
Oh, really?
Yeah, we're on I think one of the first slides actually. Yeah, like perhaps if it's a PDF, move the scroll through maybe. I don't know.
Oh shoot.
Yeah. I mean, I tend to follow verbally and not visually, so it was okay with me.
Oh, my sharing was stopped. Now is it?
Oh, okay.
I'm trying to. Is this?
Yeah, so we see the slide negatives of social distancing.
Right. What? Yeah. Oh goodness. Well, I don't know when did it? What was the? What was the last slide you saw? Oh no.
Well, we only saw the first slide, Rochelle. Sorry about that. As I said, I follow verbally, so I don't pay that much attention.
Oh no! Oh, my great slides.
Well, that's what happens with these technological things.
Well, okay. Here are study participants. Sorry, there wasn't much description there. Briefly, as you can look at this, in the positives of social distancing and some of the dimensions that I mentioned, negatives of social distancing. So here, this is now can you see this, the class membership?
Yes.
Okay. Oh my goodness, so sorry.
That's okay.
So our analysis, we came up with a 5-class structure to how people respond to patterns of responses to the positives and negatives of social distancing. We had 5 classes. Here we've labeled their overall characteristics, and in parentheses is the percentage of the sample which they comprise. So just as sort of a way to interpret this, to say, if we look at the hardships class in the purple, you look at on the left-hand side is the overall percentage of people that responded positively to the different items. So within the hardship class, about 80% of the people endorsed that they felt increased safety and security. But then when you also notice in the hardship class, let's say on a negative of family conflict, their odds of reporting experiencing family conflict are higher than the other classes. And then looking at some of the other negatives of social distancing, such as isolation and lack of freedom and financial hardships, you can also see that they're responded and endorsed those items much more than some of the other groups. So to then next say, so what were some of the sociodemographic characteristics of class membership? So the class that we labeled freedom and flexibility tended to be younger, female, and also and never married. Individuals in this sort of overall feeling of safety group tended to be older, aged about 60 years and older, white, unemployed, part of two-person households, and also living outside of the greater Montreal area. Then the group that we identified as being oriented more towards family and home tended to be in the 40 to 59 age group, married, higher incomes, larger household sizes than the other classes. Now those in that hardship class, 15% of the sample, they were more likely to be younger, non-white, living in the greater Montreal area, and also more likely to have self-reported poor mental health prior to COVID. And finally, we had this interesting sort of low impact group, and they didn't have very high endorsement of either the positives or the negatives of social distancing. And what was curious about this class is they had a much larger percentage of essential workers, people who identified as being essential workers, compared to the overall sample population. So then what do we know about the association between class membership and self-reported mental health? When we looked at self-reported change in mental health, they're reporting it as a binary response of either saying if they had experienced a significant change in their mental health versus moderate or none. But hardship class had greater odds than other classes to have reported a significant negative change in their mental health during and post-COVID. The other mental health outcome we looked at were scores on the Hopkins symptom checklist. And again, those in the hardship class had overall higher scores than those in the other four classes. So finally, to say what are some of the implications, I think in terms of this idea of conservation of resources, for us to see, a group such as those in the hardship class were overall experiencing more resource losses than gains due to COVID and social distancing guidelines. And I think also within this class to say was this relationship between pre-COVID mental health and current psychological distress to again support this idea of resources sort of traveling together in caravans. While other groups were experiencing or reported more resource gains, including time with family, flexibility in their schedules, and things like that. So in terms of the interventions, I think if we look at and say, resources are modifiable factors. And so when it comes to specifically to mental health, we can look at micro level interventions such as clinical services and telemental health, which has certainly been expanded upon greatly during this pandemic, and those individual clinical services to help people promote positive coping. And I think we also have to think more broadly around what are non-health policies and programs that can promote psychological well-being of populations. To say that it seems that we need to operationalize these concrete resources and aid, such as food and housing and financial assistance for those groups that have been hardest hit by the pandemic. And these kinds of supports outside the healthcare sector can have an impact on people's mental health and their ability to cope with the distress they're experiencing during COVID. In conclusion, I'd like to acknowledge our larger research team. This funding is from the McGill Interdisciplinary Initiative and Infection and Immunity, And if you have additional questions or would like a copy of the slides, since apparently you had very brief viewing of many of them, please feel free to contact me. Thank you.
Okay. Thank you, Rochelle. So we have about 20 minutes, I guess, for questions. So Sabah, did you have a list of questions there?
So I've been keeping track of questions on all of our social media and Zoom. Nobody has written any questions down.
Okay, all right. I have some,
okay.
if I may. Yeah,
Absolutely.
yeah. Okay. Yeah. So the first sort of question is for both Karen and Celestin, and the question is about there are alternative sort of services, as you know, in Africa, and these are the traditional healers, right? And what I'm wondering, and I don't know if you've done any studies on this directly, but you may have some thoughts on this, is that as the sort of conventional, Western sort of health services were not accessed or were accessed, is there a correlation with the degree to which traditional health services were accessed or non-accessed? I mean, sometimes, and you raised an important point, Celestin did, about the free versus non-free health services, because one of the obstacles to accessing health services is the ability to pay. And if people are not able to pay, they're more likely, I would think, to access traditional health services, right? So just some general thoughts on that, please.
Yeah, so that's a great question. It's not something that we ourselves are able to answer. Unfortunately, we don't have any data to be able to say one way or another based on what we're using, whether or not those types of health service utilization went up or down. We do know in West Africa during the Ebola outbreak, for example, people did turn to other types of services in order to, to try to get the services that they need without having to show up to the clinics where they were afraid that they might catch Ebola. So it's quite possible that would have happened again here, but we don't know for sure. We don't have the evidence to say one way or another based on what we've observed here, whether that's happened.
Celestin, do you have anything to add?
Not really much beyond what Karen mentioned. We don't have any evidence beyond what we found from the data available using routine health information data. So yeah, it will be interesting to sort of raw quantitative if there were data available.
Okay. Let's go back. Sabah, do you have any questions come up?
Yeah, so there was a question, questions for Karen and Celestin again, but perhaps we'll start with Rochelle. This is from Dr. Sanat. He asks, how can social distancing measures impact access to mental health care?
Yeah, well, I think there's been a substantial shift in terms of moving mental health services online. And here in Montreal, we have a lot of clinicians that are spending all their mental health clinicians that are doing a substantial portion of their work via Zoom and other platforms. I think that that's a very good thing. I think the challenge there is that we have to really be aware of the digital divide and to say that they're really vulnerable. Some of the most vulnerable populations may not have access to the internet and the services that would be required in order for them to use sort of virtual mental health services from their home. Now, there are clinicians that then are also then working with and still doing in-person appointments and trying to practice within community health centers using best practices. I think some of the other issues that have come up is that while there is also the issue of privacy and confidentiality with individuals that are in need of mental health services. And again, with particularly vulnerable populations, some of like youth and young adults, if they're trying to have a Zoom meeting in their home with a lot of other family members around, and maybe their issues are very much connected with family dynamics, then they're going to be less likely to be comfortable with, even if they have the internet, to have those sort of conversations. And so I think clinicians are trying to balance out when might actually it is appropriate to meet in person because of their concerns around some of the dynamics that might be going on in the home that is leading to the need for the mental health services to begin with. And also I think you have to look at if people can come in person to appointments to say, overall, we are looking at if people are in larger families where, you know, their work and their children are at home. Again, sort of the idea of like what sort of time and space do you have to even go out of your home if you could meet in person, and again, around accessing within the home for privacy purposes.
Thank you, Rochelle. It seems like a very complex issue with so many factors to keep in mind, but you're tending to them as best as possible given the conditions. Now this is another question for Karen and Celestin. It's from Dr. Sanat. He asks, given the results, can we say that the health system in the DR Congo is resilient despite its known weaknesses? I'm not sure if you wanted to address that.
I think that's an excellent question. I think, I think the question of what does it mean to be resilient is still somewhat of an open question. I think there's still a lot of room for interpretation of what that means. I think the other issue that I think hasn't been fully explained by what we've been able to look at so far is to what extent was this a very large event, real shock to the daily lives of many of the people who would have otherwise been using the health services. Another interpretation of our findings is that, for the most part, people did not feel this as a major shock. They weren't scared. They weren't really shifting their behavior in all that many ways. And so in some ways, it wasn't a very strong test of the healthcare system to be resilient. But where there was the lockdowns, it's clear that the system, wasn't able to provide the services that were probably needed to those populations. But it's unclear if it was because of the health system or just simply because of the broader social and economic factors that were preventing people from accessing the services that they want. So, I think it's a really great question. I don't know if this analysis necessarily answers it. I think another lesson that we've learned is that many of the health systems in sub-Saharan Africa have done a much better job in some ways of being able to respond to the COVID pandemic. I think the DRC is one of the countries that has seen such an enormous number of large-scale infectious disease outbreaks over the last few decades that, in some ways they are much further along. We learned that in the Ebola outbreaks, especially those in which they use the free healthcare policy, they also have now identified ways that they can help mitigate some of the impacts that do follow when there are these big outbreaks, if they put those policies into place. So I think the DRC is definitely showing some very important signs of building resilience into their healthcare system. I'm just not entirely convinced at this point that COVID was really a big test of that, or at least so far.
Thank you for that. Celestin, did you have anything to add to Karen's response?
Absolutely, yeah. I agree. It's a great question, and that is really highlighted. That need to be highlighted and explored from different angles. So I agree with what Karen has highlighted. I just want to add that some of the data we use may not be able to sort of provide a fuller picture of whether the system is really resilient, because there's some of work coming from other settings, we could look at other metrics that could help us look at. We could look at excess mortality, for example. So we're looking at services utilizations, like for Ebola, for example, we focus on the primary care services. So a use of services beyond the primary care, we don't know what happened. We also don't know the extent to which these outbreaks may have affected the overall mortality. So if we were to look on excess mortality across the country, that would also add to, to what we know or what we learned from using this data. So yeah, there is still a lot that can be done to fully answer this question.
Thank you. I'm going to leave the chat open for anyone who wants to ask another question. But in the meantime, I had a question for all three of our experts and speakers. I'm wondering what you think just public trust in the healthcare system and how that plays into the use of mental health services for people, for instance, who think COVID was not handled well by their government or by their health systems. How does that impact their own personal use of the health system, or do you think it doesn't have an impact at all?
That's a good question. I don't know if the other speakers have thoughts on that.
Yeah, I mean, so we've been doing some research on the topic of trust and how that's been shaping outbreak response, not so much in the DRC, but actually I'm involved in a project here in Hong Kong and also sort of across Asia looking at some of these questions, not specific to mental health, but to health more broadly and to response measures more broadly, like do you comply, for example, with the government's directives around social distancing and other things. I think trust is a very complicated issue. And so, we've just recently written a paper that's compared the way in which trust may have shaped the responses in Singapore versus Hong Kong. And, Hong Kong is an area where, it's been widely been seen as an area, especially in the first wave, that responded quite well to the pandemic, and that there was high levels of compliance with social distancing, high levels of measures with face mask wearing and so on. But at the same time, very low levels of trust in government. And so in some ways, the very low levels of trust in government has forced people to really begin to have to trust their neighbors. And it may be that sort of social cohesiveness that was established that really promoted these types of collective actions, especially at high levels. Whereas in Singapore, you see very different things. Very high levels of trust in government allowed for people to comply also with measures because they thought that the government was telling them the right thing. So trust is quite complicated. I think it plays a very important role in the way in which people respond to their outbreaks, but that various forms of trust and the way in which it plays out is perhaps more complicated than simply more trust is better.
Right. Thank you. That's interesting to hear about Singapore. I wasn't aware at all of that. That's really interesting. I'm not sure if anyone wanted to add anything. I know we have one question from a participant as well.
Sabah, you have Jan in Jelchim who want to speak. I don't know.
Yeah. So I will ask.
Hello.
Yes.
Hi. Yes, you hear me?
Yes.
Yes, hi. This is Ian van Engelgem. I'm a health expert working for the European Union here in DRC. I just wanted to provide some insights, maybe, if that's okay with you.
Of course.
So on the study on free provision of free care, I think the 10th Ebola outbreak in the east of Congo, we had an outbreak that was fueled to a big extent by nosocomial transmission, and especially in those health zones where you had Ebola but no free healthcare, you had a very dense urban environment in most of those areas, where with a very much unregulated health system that really fueled the Ebola outbreak. While in some of the health zones that you had Ebola and free care, which quite some of them were funded by European Union project, those were more rural, and I think that's important to make the difference because the conditions were not the same. The conditions that fueled the outbreak in those two types of settings. Also, in those in some of the districts you had Ebola, but no free healthcare. You would have quite some NGOs supporting the health systems. In some place, you would have performance-based financing for Ebola, and so all these factors might have influenced. I think the graphs we have seen. I don't know in how far that has been analyzed, but it's something I discussed with my colleagues from the development program. I'm working for the humanitarian program in the European Union here in Kinshasa. But so these are some of the issues we discussed. I think on the decrease in consultations, whether especially in Ebola, I think we have also to take into account the issue that whenever a person has fever, he would be identified as a suspect case and be hospitalized in Ebola treatment center or transit centers or whatever. And so you would have a displacement of the usual caseload to some extent. Okay, it's not, it doesn't explain everything, but I think you had thousands of patients, people that were hospitalized, for most of them for a flu, for malaria, many of them. And so these are also some of the issues that we have to take into account, I think. On the healthcare workers, the absence, there also many of them were employed. There were thousands of healthcare workers employed in the Ebola response and now in the COVID response. And so yes, you have an absence of healthcare workers in the normal health system, but they're working somewhere else where they receive some more payments often, and that's another issue that should once be discussed is the issue of payment for performance when you have to deal with a pandemic or an outbreak. I think there are some risks related to that. I think I'll stop with that. On the COVID, the second wave here in Kinshasa. So what we see is that people, meaning patients, but also the healthcare workers, that they kind of bypass the system for detecting suspected cases and referring suspected cases. People want at all costs to avoid to be hospitalized in Ebola, in COVID treatment centers. And as such, we have a whole different dynamic during this second wave than the first wave, where people will be detected in centers where they can go for a laboratory test against payment. But it's a little bit outside the health system. So resilience of health system and all that, I have some questions. If I see what is happening in this second wave here in Kinshasa, in part of Kinshasa again, I'm not sure we can really talk about resilience. Although I think that the subject is very broad, the subject of resilience, and there are certainly things that with our Western eyes we don't see. But at least for things that we see. I don't see for the moment much of resilience. Over. Thank you.
Yeah, thank you, Ian, for that. That's a very good insight. This difference between the first wave and the second wave, and I think particularly for all the studies, the presenters' studies here, I think it has implication, especially for the mental health impacts. Particularly the second wave, the pandemic fatigue, as they call it, it's really weighing in. And so I'm sure that is a significant factor, as Ian has pointed out. Now, listen, folks, we're approaching 11 o'clock, and that is the time period we have for this session. And so let me just close off by thanking all the speakers for excellent presentations, very insightful findings, very impressive and vigorous methods for sure. And I will hand it over to Sabah to announce like the next session and when it will be.
Yeah, perhaps I will hand it off to Dr. Sanat to just introduce the next session and to thank everyone for being here. But I'm more than happy to as well.
So thank you all for being here, and thank you. I didn't want to speak, but the next session will be on January 8th. And Sabah, can you tell us the title if you can find? I'm sorry, but we will have great speakers from England, Western University, and Guinea.
Yes, my apologies. I thought perhaps maybe you had the final word. So on January 16th, we have actually something that is going to be relevant to today's talk. We are going to be talking about trust and community engagement during public health emergencies from Ebola to COVID-19.
Okay, thank you. That seems very interesting. Yeah, so thanks everyone, and I'm going to close the session, and hopefully we'll be able to connect next month. I hope everyone has a happy enough holiday over the circumstances, and that everyone keeps safe and well.